Low, yes. It happened after iron supplementation. Uh, fam Primary or tertiary hyperparathyroidism PTH is high, calcium is low. Primary hyperparathyroidism. There are three causes of primary hyperparathyroidism: primary or tertiary, familial hypocalciuric hypercalcemia, and lithium. Yes, tertiary is PTH is high, calcium is low. Where is the PTH? So it is due to iron. Iron deficiency after getting iron. Okay. This patient, this patient with advanced CKD and new onset nausea. These patients with advanced CKD and new onset nausea and headache and retinal hemorrhage and a significantly elevated blood pressure consistent with hypertensive emergency. Hypertension is a common Hypertension is common in CKD. Hypertension is common in CKD patient and can be due to a variety of the causes that include medication, non-adherence, sodium and water retention, increased activity of the RAS, renin-angiotensin and sympathetic nervous system, and adverse effect of erythropoietin stimulating agent EPO and dar-epoetin. Up to 30% of the patients recovering from erythropoiesis stimulating agent, up to 30% of the patient receiving an ESA for CKD induced anemia develop a new or worsening hypertension, which typically occurs new which typically occurs 2 to 8 weeks after the treatment initiation. Hypertension is generally mild but can be severe, as in this patient the mechanism by which ESA can cause hypertension appears to be independent or increased blood volume and likely involves systemic vasoconstriction by activation of erythropoietin receptor on vascular smooth muscle cell, activation of erythropoietin receptor on vascular smooth muscle cell, heightened sensitivity of the alpha receptor, heightened sensitivity of the alpha receptor, and depletion of endothelium derived nitric oxide. Depletion of endothelium derived nitric oxide. The risk of ESA induced hypertension. The risk of ESA induced hypertension is increased by large dose and rapidly rising hemoglobin soon after ESA administration. As in this patient whose hemoglobin was 8.3 to 11.1 in 3 weeks. Following acute treatment of hypertension, subsequent ESA doses should be decreased. Subsequent ESA doses should be decreased with the goal of slowly increased hemoglobin. Yes. Tertiary hyperparathyroidism represents a progression of the secondary hyperparathyroidism, typically with CKD, such that parathyroid hormone secretion is longer inhibited by the calcium level. Hypercalcemia is present. Hypercalcemia is present and may cause and may cause the mild hypertension due to and may cause mild hypertension due to vasoconstriction, but hypertensive emergency would be extraordinarily rare. These patients' serum calcium level is low normal, not hypercalcemia. Looks like Wilms tumor because mass in the anterior left flank. Where is obsoclonus myoclonus? Oh, jerking movements in both. Oof. I was concerned in the mass in the. It can cause a left flank mass. In this scenario, like myoclonus. Okay, neuroblastoma is a childhood malignancy. Neuroblastoma is a childhood malignancy derived from primitive sympathetic ganglia. Primitive sympathetic ganglia and may arise anywhere along the sympathetic chain and or within the adrenal medulla. Most cases are diagnosed at age 2 and classic presentation include palpable abdominal mass with systemic symptoms, fever and weight loss. Patients may present with periorbital ecchymosis. Patient may present with periorbital ecchymosis, raccoon's eye, which are caused by orbital metastasis that obstruct palpable blood vessel that obstruct palpable blood vessel. Opsoclonus rapid eye movement is rare autonomic paraneoplastic finding that may present in conjunction with myoclonus or rhythmic jerking of the trunk or extremities is called opsoclonus myoclonus syndrome. Okay, why it is not WIMS? WIMS is the common pediatric renal malignancy. WIMS tumor and neuroblastoma can present similarly with the systemic symptom and abdominal mass. However, periorbital bruising and opsoclonus are the finding associated with neuroblastoma. We I ignored this point. There is no hemolysis. It is febrile but non-hemolytic. Okay, febrile no, if we look at the box, 0 to minutes anaphylactic, from 1 minute to 1 hour acute hemolysis, there may be hemolysis. So in hemolytic, direct antiglobulin will be positive, but in here direct antiglobulin is the Coombs test, so Coombs will be positive if it is acute hemolytic. Then 1 hour to 6 hour it may be febrile non-hemolytic tachotrally TTT tachotrally for tacofrusamide for trally respiratory, and for transfusion transmitted bacterial infection antibiotic and urticarial. In urticarial and anaphylaxis, like in urticarial we will give antihistamine, and for anaphylaxis we will give epinephrine. Okay, and from 2 days to 10 days delayed hemolytic. Okay, febrile non-hemolytic transfusion reaction. Febrile non-hemolytic transfusion reaction, the most common adverse transfusion reaction is a benign occurrence caused by cytokine release from leukocytes within the donor blood product. During preparation of a blood product, whole blood is separated into red blood cell and plasma. Whole blood is separated into red blood cell and plasma. However, small amounts of leukocyte debris remain in the red blood cell concentrate. During blood storage, these leukocytes can release cytokines, which when transfused can cause transient fever, chills, malaise within 1 to 6 hours of transfusion initiation. Management includes transfusion cessation to exclude other serious reactions and antibiotic administration. Risk of recurrent febrile non-hemolytic transfusion reaction is high after first episode, and prevention is best achieved by using leukoreduced blood product for further transfusion. Leukoreduction involves filtering out of most of the leukocytes after blood collection, out of the leukocyte after blood collection but before blood storage, thereby minimizing cytokine production within the packed red blood cell product. Leukoradiation also reduces the risk of human leukocyte antigen alloimmunization and transmission of CMV, which typically resides in the leukocytes. Many facilities empirically leukoreduce all blood product, but this process is not universal. Uh, this one is maybe important. Soya based formula feed. Continue to soya based formula. Maybe. And in breast milk also, uh, there is low iron and vitamin D. Maybe. I don't know. Other does not fits hemoglobinopathy. Hemoglobin. Yes, normocytic normochromic anemia. And yes, hemoglobinopathy, sickle cell, maybe. Think otherwise. No. Okay. It's a physiologic anemia of infancy. A physiologic anemia in infancy pathogenesis, increased tissue oxygenation at birth, down regulation of the erythropoietin. Increased tissue oxygenation at birth, down regulation of the erythropoietin. Asymptomatic term infant, age 2 to 3 months. Normocytic normochromic normocytic anemia, hemoglobin 9 to 11, low to normal reticulocyte count. Reassurance: anemia resolves with increased erythropoietin drive after 3 months. Preterm infant have lower nadir at a younger age, anemia of prematurity. Okay, this patient has this patient had warning. This patient had warranting a complete blood count which revealed anemia and leukopenia. Repeat evaluation shows resolution of the leukopenia, which therefore was likely to transient bone marrow suppression in the setting of infection. However, this child's anemia is persistent in asymptomatic patient aged 2 to 3 months with a normocytic anemia. The most likely cause is physiologic anemia of the infancy. Physiologic anemia of the infancy is a transient decline in the hemoglobin due to downregulation of the erythropoietin triggered by a sudden increase in tissue oxygenation at birth. Red blood cell production in the bone marrow slows and leading to physiologic hemoglobin nadir at around 11 at age 2 to 3 months. In term infant, can be as low as 9 milligram per deciliter. Although the absolute value of the reticulocyte count may be the normal, the compensatory reticulocyte count in response to anemia is absent. After 2 to 3 months, the erythropoietin drive returns and hemoglobin level rises. Physiologic anemia of the infancy is asymptomatic and may be identified on lab evaluation or other purposes, as in this case. Findings suggestive of pathological cause of anemia such as hemoglobin less than 9 gram per deciliter and signs of hemolysis, elevated reticulocyte count, or microcytosis are not present. Yes, iron deficiency anemia, there is decreased dietary iron, low iron absorption, can cause microcytic anemia, low MCV, which is not seen in here. Low MCV is not seen in here. The diagnosis is rare before 4 to 6 months because iron stores in young infants are derived from the mother in the utero. Okay. Sickle cell anemia, sickle cell disease. associated with sickle cell disease associated with intravascular hemolysis does not cause anemia until age 4 to 6 months due to predominance of fetal hemoglobin in young infant. Moreover, this condition or other hemolytic disorder G6PD deficiency, hereditary spherocytosis, cause a compensatory reticulocytosis, in the setting of the anemia, which is not seen in this patient. In addition, other common hemoglobinopathies, thalassemia diagnosed by hemoglobin electrophoresis, would cause microcytic or normocytic anemia. Okay, okay. Um, age of onset 0 to 3 months. 0 to 3 months. Pathologic is congenital infection, hemolysis, ABO incompatibility, and spherocytosis. And physiologic is uh, 0 to 3 months, it may be pathologic, it may be physiologic. Pathologic if it is symptomatic, if age is less than 1 month and hemoglobin is less than 9, and microcytosis. 4 to 6 month hemoglobinopathy, thalassemia, hemoglobinopathy like thalassemia and sickle cell disease, and more than 6 month iron deficiency. So more than 6 IDA, 4 to 6 hemoglobinopathy, 0 to 3 congenital, and ABO incompatibility or spherocytosis. No, oxidative burst is not the answer. Okay. His this is the clue. Like he has prolonged hospitalization and extensive surgery. A gunshot wound. Maybe spleen is gone. So splenectomy. Okay. That's why this gram-positive organism is okay. I got the wrong too. Okay. This patient, I was confused in between D and E. Okay. So this patient likely has splenectomy this patient likely has a splenectomy during his operation for multiple gunshot wounds to the abdomen. He now has high fever, hypotension, tachypnea, tachycardia in the setting of bacteremia with gram-positive cocci, suggestive and overwhelming strep pneumoniae. Encapsulated organisms such as strep pneumoniae, Haemophilus influenza, initially meningitis have a polysaccharide exterior that conceals antigenic epitopes and resists innate phagocytosis. Therefore, these pathogens are largely eliminated via the humoral immune response with antibody-mediated phagocytosis opsonization and antibody-mediated complement activation. Much of these dependent on the splenic macrophages and the generation of the splenic opsonizing antibody. As such, patients with asplenia are at high risk for fulminant infection and encapsulated organism. These patients should be immunized with pneumococcal, meningococcal, and Haemophilus influenzae type B vaccine and take oral antibiotics early in the course of any febrile illness. Yes, deficiency of the complement can be inherited or acquired, like SLE, antiphospholipid antibody syndrome, can increase the risk of infection with encapsulated bacteria, classic complement pathway. However, such deficiencies are rare and splenectomy is far more likely to be the cause of this patient's bloodstream infection given his history of multiple abdominal gunshot wounds. CD4 lymphocytes are destroyed by HIV and patients are at increased risk of infection with uh, with a wide range of pathogenic organisms including uh, encapsulated bacteria. However, this patient is more likely to have asplenia with defects in and antibody production and antibody mediated phagocytosis. Okay, CNE, impaired B cell isotype switching is seen in some patients with CVID. They have normal B cell numbers but significant reduced immunoglobulin type. However, with CVID are at risk for recurrent infection, sinopulmonary, gastrointestinal, and autoimmune disease. Patients with IgA deficiency are often asymptomatic and rapid. Fulminant infection is uncommon. The patient is far more likely to have a splenectomy. And F, like chemotaxis is impaired in patients with leukocyte adhesion deficiency. Patients with this condition have recurrent bacterial infection, particularly of the skin and mucosa. And the G, patients with CGD, chronic granulomatous disease, have impaired oxidative burst and often present with recurrent bacterial or fungal infection due to catalase producing organism. Aspergillus nidulans, Staph aureus Host response against pneumococci catalase negative is not affected by the oxidative burst injury deficiency. Sickle cell trait. No, if it is disease, then S would be higher and A would be far lower. It is acute chest syndrome dactylitis. This is for sickle cell disease, isn't it? And osteomyelitis, it is also the sickle cell disease. Is it hematuria? Okay, I don't know the answer. Okay, hypostenuria. Okay, so sickle cell disease is sickle cell disease is a hemoglobinopathy with autosomal recessive inheritance. When both parents carry the trait, their children are at risk of inheriting the disease. These patients' hemoglobin electrophoresis pattern and complete blood count are consistent with bearing the carrier for the sickle cell trait. Individuals with sickle cell traits generally asymptomatic and can lead to healthy life, although patients are at increased risk for renal issues. The most common the most common of these painless microscopic or gross hematuria results from sickling in the renal medulla. Hypocysteria, impairment in concentrating ability is also common and can present as nocturia and polyuria. Less commonly, there may be increased risk of UTI, particularly during pregnancy. Splenic infarction are uncommon but can occur at high altitude. Yes, okay. In sickle cell trait, look, in sickle cell trait, hemoglobin A is much more, not like the normal, but A2 is present and F is present and S is 3 plus. Like in sickle cell trait, A and S is nearly 50-50% and C is absent. In sickle cell patient with hydroxyurea and in hemoglobin SC disease, all of them has absent hemoglobin A. This is the important part. Sickle cell anemia on hydroxyurea and hemoglobin SC disease, all of them has absent hemoglobin A. And in sickle cell anemia there is increased hemoglobin S and S SCA on hydroxia, there is hemoglobin S, but there is also increased hemoglobin F. We know that hydroxyurea actually increase fetal hemoglobin like hemoglobin F. That's why the hemoglobin is slightly higher from the other parameter. Okay, and hemoglobin C is commonly absent, all of them, but in SC disease, S and C is nearly 50-50% present and A is absent. Okay, chronic lymphocytic leukemia is the most common type of leukemia in the US. Is almost always seen in elderly. Median age at diagnosis is 70. Patients are often asymptomatic but can present with extreme fatigue, symptoms, night sweat, fever, infection, weight loss, lymphadenopathy and splenomegaly. Lymphadenopathy and splenomegaly are often present on physical examination. Dramatic lymphocytosis is the classic hallmark of CLL. Peripheral smears reveal mature lymphocytes with the presence of smudge cell, pathognomonic feature of the CLL. Okay, your wish. Okay, then we will do tomorrow. Okay, okay, bye bye.